Hello. It is my pleasure to welcome our speaker today, Dr. Steve Ferrone, for our Truist-sponsored educational webinar entitled Advances in the Genetics of ADHD, Implications for Clinicians. Dr. Steve Ferrone, PhD, is a distinguished professor in the departments of psychiatry and neuroscience and physiology at SUNY Upstate Medical University. He is president of the World Federation of ADHD and program director for www.adhdinadults.com. His research studies of ADHD include genetics, epidemiology, neurobiology, and psychopharmacology. And without further ado, we hope you enjoy this webinar recording.
Welcome. Happy to be talking to you today about a topic that has been dear to my heart for about 30 years, the genetics of ADHD. First, my financial disclosures. I do consult with a number of companies that make pharmaceuticals or devices for ADHD. None of them have supported the preparation of this talk, although I do receive an honorarium from Truist for presenting today. I've kind of broken this down into things that I've learned over the past 30 years. This first slide covers what probably 15, 20 years ago, I would have done a whole talk about the heritability of ADHD because we had no data on the molecular genetics. There are now 38 studies that have looked at the heritability of ADHD, mostly twin studies. Now, heritability is a statistic that ranges from 0 to 1, and it assesses the impact of genes and their interaction with the environment on the expression of ADHD in the population. These studies clearly show, and you can see this, it's dramatic across all of these studies, heritability is averages to about 75%, 74%, which is about as heritable as schizophrenia or bipolar disorder. Extremely important. Well, why should clinicians care about the fact that ADHD runs in families? Well, first of all, about 25% of parents who have children with ADHD may require treatment for ADHD and or some of the comorbid disorders. Parental ADHD is known to interfere with the implementation of both medical and psychosocial treatments for ADHD. So it makes sense to screen parents of ADHD children for ADHD. And the same can be said for the siblings of youth with ADHD. They're also at high risk for ADHD and should be screened for the disorder. Moving on to the molecular genetic age, which really started in the 21st century, I was privileged to lead an international group that that created a very large molecular genetic study of over 50,000 patients and controls that taught us that ADHD is a polygenic disorder where thousands of common genetic variants contribute to the risk for the disorder. So there's no single gene that causes most cases of ADHD. Yes, there are certainly rare variants where a single gene will cause ADHD, but those are rare. We're talking, 1 in 10,000, 1 in 20,000 people, 1 in 20,000 cases. But most common variant ADHD is caused by, now we estimate 7,000 genes, or better said, genetic variants contribute to the risk for the disorder. Now, this is very consistent with what we know about symptoms in the population. The symptoms of ADHD are normally distributed. And the mathematics of genetics would tell us that with 7,000 genes leading to the disorder, you would expect a normal distribution of symptoms in the population from low extremes to high extremes, with no natural cut point between who has ADHD and who doesn't. Now, we've known about this symptom distribution for some time, and it certainly led many of us to suggest that the subthreshold symptoms for ADHD may be driven by the same genetics and probably the same environmental etiologic factors as the disorder itself. And in fact, in this big international study I told you about, we computed the genetic correlation between ADHD diagnosed as a disorder and then quantitative ratings of ADHD symptoms in the population, and that was almost 1, 0.97. And it tells us that the genetic regulation of ADHD symptoms in the population is the same as the genetic regulation of the disorder of ADHD, which suggests that subthreshold symptoms may be meaningful. I'll get to that more in just a little bit. Now, I mentioned the polygenic risk for ADHD. We have 7,000 variants that are implicated. That leads to not only a normal distribution of symptoms, but there's a normal distribution of polygenic risk in the population. For those of you who keep track of the research and clinical research literature, you will start to see polygenic risk scores for ADHD being discussed in the literature. And that's why you need to know what they mean. Essentially, polygenic risk score simply means if you have a high polygenic risk, you're at high risk for ADHD. A low polygenic risk, you're at low risk for ADHD. This risk score is currently not accurate enough to actually diagnose ADHD, but it has been very useful in the research world for shedding light on many issues in ADHD, which we will discuss. Perhaps the most important clinical implication of polygenic risk is that ADHD, like hypertension, is the extreme of a quantitative genetic trait in the population. Sometimes subthreshold hypertension must be treated when indicated by other high-risk features of the patient. The same is true for ADHD. Importantly, subtypes of ADHD don't make sense in a quantitative framework, and many of you know that the DSM-4, I believe, instituted subtypes of ADHD. The DSM-5 got rid of the subtypes because many of us did research showed that they really weren't valid, and they were simply changing presentations of the disorder. But importantly, substantial data now indicate that subthreshold ADHD can be an impairing disorder that requires treatment. With my colleagues at the Mass General, the Biederman group, we wrote a paper about subthreshold ADHD where we meta-analyzed much data from around the world that looked at subthreshold ADHD. Now, I know you can't read these slides, these data points. I'm just showing them to give you a sense of how much data are actually available on this topic. On the left here is really take-home points. Not surprisingly, subthreshold cases of ADHD are milder than full threshold cases, but when you compare them with controls, typically developing controls, these subthreshold cases of ADHD show more psychopathology, more school failure, more neuropsychological impairment, more substance abuse, more psychosocial impairment. They essentially show the same profile of associated features that we see in ADHD, but at a lower level. Again, more evidence that subthreshold ADHD is clinically significant, which is very consistent with the genetic data. We should pause for a second and consider some of the diagnostic issues for subthreshold adult ADHD, because diagnosing adults with ADHD who have subthreshold symptoms is particularly difficult. And part of this is because retrospective recall for adults is not easy. And in fact, there have been research studies now that document that adults who are known to have ADHD in children have a difficult time recalling their symptoms from childhood. In fact, they're less likely to report symptoms in childhood than people who don't have ADHD. And so one has to be skeptical of the retrospective recall. It can be faulty. Many adults with ADHD who have subthreshold symptoms have a less severe form of ADHD and a history of supportive and well-structured home and school environments that protected them from their ADHD emerging. I like to think of that as a psychological and some intellectual scaffolding. For example, a person with high IQ, their high IQ protects them from the emergence of ADHD symptoms. Their parental support protects them, but symptoms can emerge later in life when some of that scaffolding disappears or when the stresses of life become more pressing on them. And of course, there's sometimes self-medication in the history of the adults with ADHD. And we have subthreshold ADHD, we have subthreshold cases who actually have many symptoms. It's, in my opinion, bizarre that somebody can have 5 inattentive symptoms and 5 hyperactive impulsive symptoms, but not meet criteria for ADHD because they don't pass the DSM-5 threshold. So we also think that DSM-5 may have a low sensitivity for some cases of adult ADHD because they don't include criteria for emotional dysregulation and executive dysfunction. These are associated features of ADHD, not symptoms, but some of us, including myself, think these ought to be diagnostic criteria in adulthood when hyperactive impulsive symptoms tend to attenuate, but these emotional symptoms and symptoms of executive dysfunction increase. The dimensionality of ADHD that's supported by genetic studies has a big impact for our concept of diagnostic error. The concept, one reads in the media that errors are being made in the diagnosis of ADHD. It's overdiagnosed, typically is what you read in the media. And the categorical model of the disorder implies that overdiagnosis is this huge error because it's comparing the child has ADHD or they're neurotypical. There's nothing in between. A dimensional model obviously implies degrees of error, and part of that degree of error is this subthreshold case. And my suspicion is that many of the so-called overdiagnosed cases actually have subthreshold ADHD. One example of a question that arises from the research literature is, how should you diagnose youth who are young for their grade in the classroom? There have been a number of studies now that show that these youth who are young for their grade in the classroom are more likely to be diagnosed with ADHD than not. And the psychiatric and medical professions and psychological professions have been criticized for this. And yet these kids very likely have had a subthreshold form of ADHD, which then emerged in these classrooms when they were exposed to environments that were more challenging for them because they were the youngest in the classroom. So when we look at these types of cases from a dimensional mechanistic model, they begin to make more sense as clinically valid cases of the disorder. Our genetic studies, or molecular genetic studies, also, we're trying to shed differences on sex differences, but so far what we find is that the genetic correlation between males and females is almost perfect. In fact, it's for all intents and purposes, it's 1.0, it's perfect. And this tells us that the common genetic causes for ADHD do not differ between males and females. It seems to be essentially the same genetic condition from a common variant perspective. Now, what are the clinical implications of this lack of sex differences? Now, it doesn't mean that you won't see different manifestations of the disorder in males and females. And in fact, girls frequently present with the predominance of inattention over hyperactivity and impulsivity, and are sometimes not referred because of that, or sometimes missed in screening. So one has to be careful when screening for ADHD in girls to pay attention to the inattentive behaviors. Because the genetic data suggests that the disorder, being similar in males and females, suggests that differential diagnosis and treatment is not warranted. And what I mean by that is that we shouldn't be treating females as having a different kind of ADHD than males. And I've seen some of my colleagues tend to talk about that, and I disagree with that. ADHD in males and females is the same disorder with some differences in manifestation. Really interesting findings from the molecular genetic studies has to do with what we call gene-environment correlation. We tend to think of genetics and environment as separate adversities that affect people to cause disorders. And that is true. Genes and environment combine to cause disorders. But it's also true that genes and environment can be correlated with one another. What this study showed here is looking at the polygenic risk for ADHD and is correlating that with it's correlating the polygenic risk of a child with adversity in their environment. All of these adversity indicators that this graph tells us, because all of these blue dots are to the right of this vertical line, all of these adversity indicators are positively correlated with the molecular genetic risk for ADHD. Now, it seems bizarre, but it means that a child having been, children who are physically abused, emotionally abused, are more likely to have a high polygenic risk for ADHD. Well, and why is that? Well, it could be that, very likely, I should say, that because they have a high polygenic risk for ADHD, their parents have a high polygenic risk for ADHD. Because that polygenic risk for ADHD is associated with not just ADHD, but other disorders like substance abuse and conduct disorders, antisocial disorders, that could explain why they then get exposed to this physical and emotional abuse. Very, very important data. So when you diagnose kids that live in adverse environments, don't assume that the adversity caused the ADHD and they have a different ADHD, that it's somehow situational, unless it's very clear that their ADHD only occurs in one environment. That's a special case. But I've seen some clinicians say, oh no, this child has environmental ADHD and I need to treat it differently. They don't need medication, they need a special kind of psychosocial therapy that deals with their environment. That's rarely the case, that it's a special kind of ADHD. We know that the environmental causes of ADHD, when they occur, have small effects like the genes, and they have additive effects that combine with genes to cause ADHD. It's only in rare cases that adverse environments cause ADHD on their own. Similarly to adverse environments, excuse me, parental ADHD is also correlated with polygenic risk for ADHD. So here we have father's education level going from having only completed primary school to having a PhD. These are the polygenic risk for this is polygenic risk scores for people who have ADHD, and I'm sorry, people who don't have ADHD in blue, and people who have children who have ADHD in red. So the children who have ADHD always have higher polygenic risk for ADHD, but at the primary school level, meaning for fathers who only completed primary school, the polygenic risk for ADHD is higher than it is for fathers who had more education. Again, another example of this gene-environment correlation. So it's also true that IQ is negatively correlated with polygenic risk for ADHD. So clinicians should be aware that some parents of youth with ADHD may not have sufficient intellectual resources to understand, implement, and adhere to treatment regimes, and they might require special help for that. Now, these data, I love these data. I was happy to participate in this study, which came from a group that specializes in ADHD out of Barcelona, Spain. What they have done here is to do a genomic analysis of the natural history of ADHD by using genetic samples from ancient Neanderthal samples. Now, I can't go into how they can do this, but essentially what they show, because they can, we know what the risk, we know some of the risk genes for ADHD, and we have access to these ancient samples that were collected basically by scientists getting DNA out of bone from ancient Neanderthal samples. We're able to look at what has happened to the frequency of ADHD genes over time. And it turns out in each of these are 3 different experiments done with 3 different sets of ancient DNA, and that's why the time scale differs. But you can see here, going back 36,000 years, the prevalence of ADHD genes was relatively high and decreased between 36,000 years ago and 8,000 years ago. We see the same thing from about 12,000 years ago to 3,000 years ago, and the same thing here on a smaller time scale. So the frequency of ADHD genetic variants has decreased since Paleolithic times. So why is this interesting to clinicians? Why should you know about this? Well, first of all, we sometimes hear that ADHD is a new disorder caused by the stress of fast-paced, high-productivity environments, particularly American environments. That's not true. The disorder has been with us for tens of thousands of years, and in fact, it's been decreasing in frequency because the genes for it have been, the genetic variants that cause it have been decreasing in frequency. Why do they decrease in frequency? They decrease in frequency because having the genes for ADHD make it difficult to adapt to environments. So patients and caregivers need to know that these data provide us with further, I think, impressive support for the conclusion that ADHD is a biological disorder that's been with us for quite a long time, and it may require treatment aimed at its biological effects. Based on these data, can we use DNA to make psychiatric diagnoses? Simple answer is no. These scores are not sufficient for psychiatric diagnoses. I expect that accuracy will improve as our samples get larger and more sophisticated, and indeed my group is working on this right now. But as of now, these scores are not useful. They are, however, useful for exploring associations between ADHD's polygenic risk and other outcomes. So here we see on the horizontal axis, we're plotting low, medium, and high polygenic risk for ADHD. And on the left, we see that as polygenic risk for ADHD increases, in a population of adolescents not selected for ADHD, those with high polygenic risk tend to have achieved a lower level of education. They're more likely to be arrested, and they're more likely to have high levels of perceived stress in their environment. So we see the polygenic risk for ADHD is driving these negative outcomes in the population, regardless of a person having ADHD. These results remind us that documenting functional impairment is essential to diagnosing ADHD. It is part of the genetic makeup of this disorder to lead to functional impairments. Very importantly, failure to document functional impairment has been documented to lead to false positive diagnoses. That's probably one of the biggest causes of false positive diagnoses that have come out of meta-analytic studies of prevalence. Let's move on to the third lesson here, and that is that the causes of comorbidity in psychiatric comorbidity in ADHD are partly genetic. So I've told you about polygenic risk scores, which is simply the risk for ADHD or the risk for another disorder that we get by counting up the number of risk variants that a person has and giving them a score. We all have a polygenic risk for ADHD. We all have a polygenic risk for depression. And because we can compute these scores now, we can compute the correlation between the risk for ADHD and the risk for other disorders. So we were able to do that in a very large group called the Psychiatric Genomics Consortium, to which I helped found about a decade or so ago. This is showing here the correlation between many disorders. These boxes here, which I've highlighted for you, show that ADHD has significantly positive genetic correlations with schizophrenia, depression, bipolar disorder, antisocial disorder, Tourette's syndrome, and negative correlations with anorexia nervosa. Some of these comorbidities were known in advance from studies that were done back in the 1990s. Some are relatively new, like the association between ADHD and schizophrenia was not expected from clinical studies that we had done. These data are very important because psychiatric comorbidity is not a diagnostic artifact. Back in the 1990s, there were huge arguments about this. People told me that, no, your patients can't have depression. You must be making a mistake. They have ADHD or depression. They can't have both. They have ADHD or autism. They can't have both. Today, we know that psychiatric disorders are correlated with each other at the level of their DNA. And so you as a diagnostician should expect pervasive comorbidity, that ADHD can and does and will co-occur with many disorders. And in fact, multiple comorbidities are to be expected in some patients. In addition to their psychiatric comorbidities, we're beginning to learn a bit now about ADHD's association with medical conditions. Here, for example, is the genetic correlation looking at obesity and lipid levels. So these genetic correlations here show that ADHD is correlated with all these measures of obesity, positively and significantly correlated with all these measures. Remember, this is the genetic correlation between the genetics of ADHD and the genetics of these other conditions. ADHD also correlated with not just obesity, but also with lipid levels. We know that ADHD is genetically correlated with other traits such as smoking, even getting lung cancer. Some traits such as age of the first birth of the child is genetically correlated with ADHD. This is not, what I mean by this is if you look into a population of people not selected for ADHD, those who have higher risk for ADHD based on their genetics are more likely to have had their first child born earlier, which is consistent with the fact that we know that ADHD people themselves tend to have early sexual activity and are more likely to have children at early ages. There's also a correlation between the genetic risk for ADHD and earlier than expected death, which again is consistent with epidemiologic data showing that people with ADHD are at risk for premature death. So the implications of somatic comorbidity are that patients with ADHD should be screened for these somatic comorbidities. Because ADHD also worsens some somatic outcomes, some patients may need cognitive behavior therapy modules that focus on helping them manage diseases like diabetes, asthma, and obesity. Primary care doctors should screen patients with ADHD for these disorders. Importantly, the genetics of ADHD are beginning to tell us something about the mechanism of how ADHD develops in the brain. We're a long way from understanding mechanisms. I'll tell you a few brief things. Number one is that when we partition the polygenic risk for ADHD by types of tissue, we find that ADHD genes are expressed primarily in the central nervous system. Highly consistent with what many of us have said for decades, that ADHD is a disorder of the brain. It's not a disorder of the pancreas or the kidney or the liver. It's a disorder of the brain. The genetic data are very clear in indicating that for sure. Yet, due to misinformation, some people still view ADHD as a disorder that's due to poor motivation, claiming they're just lazy, or poor parenting, parents aren't doing a good job. This blame the parent approach or blame the patient approach creates stigma, and it worsens access to treatment and adherence to treatment. The genetic data support neuroimaging data that establishes ADHD as a brain disorder like any other brain disorder that is rooted in part in one's biology. So to reduce stigma, this information should be communicated to patients and to parents. We're also seeing that the genomics of ADHD is helping to clarify the onset and persistence of ADHD. The common genetic variants that we've been talking about are mostly the same for ADHD when we study children and when we study adults. The correlation is about 0.8. It's not perfect, which tells us that there are likely some genes that regulate the onset and the persistence of the disorder. We have to yet disentangle those genes. Quite interestingly, when we look at different types of ADHD based on persistence and onset, here we see different polygenic risk scores. So for people this is a population study, a study of ADHD in the population. People who have low levels of ADHD symptoms have polygenic risks that are essentially 0 and not consistent with having ADHD at all. People who have ADHD that's limited to childhood have very low ADHD risk scores, but a little bit higher than people without ADHD. People who have persistent ADHD here have much higher polygenic risk scores, as one would expect. They have a more severe genetic disorder, persists into adulthood. Interestingly, those who had adolescent onset, and this is after the DSM threshold of age 12, they tend to have lower genetic risk as well, suggesting that it's a milder form of the condition. I've been thinking about the clinical implications and how we should think about late onset ADHD. It's been something that's interested me for quite some time. I've written a bunch of articles about this. So when onset occurs later than the DSM requirement of age 12, we have to keep in mind that it may have been delayed for several reasons. The patient could have had a milder condition, subthreshold ADHD we discussed. They could have had that social and emotional scaffolding that protected them from ADHD. Or it's possible the patient had a childhood onset but cannot recall the symptoms. Now, clinicians should always be cautious about diagnosing late onset ADHD, but you should never rule out the diagnosis of ADHD just because you can't establish the onset prior to age 12. So actually, this less than 7 is really pharmacogenetics. That slide had the wrong label. I apologize for that. So one of the dreams of those of us who have worked in the area of the genetics of ADHD is that we could make pharmacogenetics theory turn into practice, that we could divide a syndrome up into different subgroups, instead of having one treatment based upon the specifics, details of the genetic variants, we could get to a precision medicine where the patient's genome would tell us which drug should be prescribed. It would be wonderful if we could get there. So where are we with ADHD? Well, we do know from many studies that have looked at the pharmacokinetics of ADHD drugs that there are DNA variants that do control how drugs are metabolized by people with, or people without, even people without ADHD. They control metabolism in anyone. There are some rare CES1 variants that lead to poor metabolizers of methylphenidate. 20% of Caucasians are poor metabolizers of amphetamine due to CYP2D6 variants. Cytochrome P53A4 variants appear to explain ancestry group differences in amphetamine, and they're known to be ultra-rapid metabolizers of atomoxetine due to CYP2D6 polymorphism. Polymorphism is just a variant of the gene. This has to do with the pharmacokinetics of the disorder. How does it metabolize and distributed in the body so it can get to the site of action in the brain? Other studies have looked at the pharmacodynamics of drug response and its association with genetic variants. In 2018, I published this review where we concluded, based on a number of prior studies of these particular genes, that all of these genes except for LPHN3 showed a significant association with the response to methylphenidate, meaning that we're able to predict statistically significantly methylphenidate response. But as you can see, the odds ratios are fairly low, which means that the predictive accuracy was not dramatically high, even though the statistical significance was high. For most of these studies, there was no publication bias, which is a good thing. There was, however, publication bias for this gene here, which happens to be the dopamine transporter gene, which is the target of methylphenidate. So we're less certain about those results. We're more certain about the D4 dopamine receptor. This is the norepinephrine transporter, catecholamethyl transferase and the ADRA2A receptor. Well, we know we have clinically significant results for pharmacokinetics and pharmacodynamics. Is it clinically useful? Well, unfortunately, not so clinically useful. And why is that? Well, the effects on drug metabolism are real and theoretically useful, but clinicians have for years detected fast and slow metabolizers by slow titration in clinical practice. And so usually that hasn't been a problem. The effect of the DNA variants on the pharmacodynamics of ADHD, the response to symptoms, they're real, these effects, but they're weak. And so they're really not good enough to predict who's a responder and who's not a responder. Because the types of studies that have been done so far are not the types of studies we need to document whether a pharmacogenetic marker is useful. This is important for you to understand because people will come to you trying to sell you kits to do genetic polymorphisms to diagnose ADHD. And they'll base it based on the kind of data I presented to you as opposed to what you really need, which are randomized controlled trials comparing treatment as usual with pharmacogenetically guided treatment. Now, their second best studies are electronic medical record studies comparing treatment as usual with pharmacogenetically guided treatment. These have not yet been done for ADHD. However, studies of pharmacogenetically guided treatment have been done for depression. These have generated a lot of controversy. On the one hand, for example, the paper here shows that pharmacogenetically guided treatment is associated with increased adherence and cost savings. There was, however, this very large multi-center trial which failed to meet its primary outcome, and it concluded that pharmacogenomic testing did not significantly improve mean symptoms, which was their primary outcome, but it did significantly improve their secondary outcome, which was response and remission rates. Now, because of these types of ambiguous outcomes we've seen for pharmacogenetic trials, there's been a lot of criticism in the literature that you need to know about. This was a very good viewpoint article in JAMA Psychiatry that looked at the quality of studies. And you can see that in this table here, which I'll show you blown up here in this next slide. Essentially, what this tells us that this is the ideal protocol. There were no studies yet with pharmacogenetically guided treatments of depression, certainly none for ADHD that have used the ideal protocols. And this is a problem because all of these other types of methodologies are somewhat biased to show positive findings when their positive findings don't actually exist. Why are they biased? Why are these studies biased? Well, because in many studies, treatment as usual is far below the standard of care. And so if you compare pharmacogenetically guided treatment, which is not just using pharmacogenetics, but it's also implementing best practices, then it's going to do better than treatment as usual, as long as they're keeping clinicians within the boundaries of evidence-based care, which is what they tend to do. So when PGT is better than tau, we don't know if it is due to the use of pharmacogenomic information or the use of standardized care protocols. So as you can see, I'm somewhat skeptical about pharmacogenomics. What does the FDA say? FDA is very clear. They looked at all these data and they said the relationship between DNA variation and the effectiveness of antidepressant medication has never been established. I'm showing you this information about depression because pharmacogenomic data, pharmacogenomic kits are now being sold, not just for depression, but also for other disorders that you treat, including ADHD. So this FDA statement, applies even more strongly for ADHD, where there's absolutely no data from the clinical trials perspective. If we look at not just the FDA, of course, but FDA is not perfect. They do make mistakes. Look at the American Psychiatric Association. They essentially came up with the same conclusions. Data supporting gene testing claims are flawed because associations are weak. Effects of pharmacokinetic genes are mitigated by titration. Poor clinical trials, failure of primary outcomes. Importantly, lack of transparency, which is a big problem with some of the pharmacogenomic kits. They don't really tell us how they're drawing their conclusions. When the Child Psychiatry Association reviewed pharmacogenomics, essentially these are the same conclusions. I'm not going to read the slide. They did say, however, that tests for drug metabolizing enzymes may have some utility in patients with abnormal side effect profiles and treatment-resistant conditions. So in rare cases, these tests can be useful to kind of figure out how come somebody is not responding to expected treatments. Point out that there are some unintended consequences of pharmacogenetically guided therapeutics. Number one, you've got to read a big report that they send you, and the time spending in interpreting the data might be better spent on doing something else. And number two, there has been some documentation that sometimes following pharmacogenetic guidance decreases adherence to well-validated evidence-based treatment guidelines. And that's an important negative for pharmacogenomics. If it tells somebody to use, for example, for ADHD, where a mainline treatment is typically a stimulant, where it says, no, this person is a poor metabolizer, you need therefore to go to a non-stimulant, that might not be the best choice for that patient, depending upon their individual situation. So the clinicians really, pharmacogenetics is far from replacing clinical acumen in this person's opinion. If you're interested in pharmacogenomics, go to follow CPIC. They provide some of the best data on pharmacogenomics that's coming out on a regular basis. The URL is here, cpicpgx.org/guidelines. So let me summarize before we go to the questions. Some of the lessons I think are the main important lessons that I've learned over the 30 years or so I've been studying ADHD genetics. First, something we started to observe in the late 80s and 90s, ADHD runs in families. Parents and siblings of your patients are at high risk for the disorder. You need to know that and deal with it. Genetic studies support the idea, and I'm talking about molecular genetic DNA studies support the idea that ADHD is the extreme of a continuous trait, kind of like hypertension. Among other things, it suggests that subthreshold symptoms will be meaningful in some patients, and diagnosing young for grade youth may be appropriate. Psychiatric comorbidity is common in ADHD and typically not a diagnostic artifact. Many of your patients, for those of you who are working primary care who have mood and anxiety disorders, are likely to have ADHD too, and that it's important to screen them for ADHD. Importantly, the genetic risk for ADHD we know now is expressed in the brain. This is incontrovertible from this. Remember, this is a very large genomic study, over 50,000 people in it. Therefore, you can teach your patients and their parents and caregivers that ADHD is a brain disorder. Somatic comorbidity is also real and genetically driven. You'll be seeing a lot more about this coming out soon. A lot of us now are doing studies in somatic comorbidity. Screen your patients with ADHD for these comorbidities. And if you work in primary care, you really ought to be screening some patients who have these somatic comorbidities for ADHD. Because we do know, for example, for diabetes, that having ADHD worsens diabetes outcomes. Late onset ADHD can be a valid form of the disorder, but it does require caution in diagnosis. We cannot yet use DNA to diagnose ADHD. I hope we can get there in the future, but we're not there yet. And as far as pharmacogenetics goes, DNA variants are indeed associated with both pharmacokinetics and pharmacodynamics, but utility in the clinic has not yet been demonstrated. So keep that in mind when someone tries to sell you a pharmacogenetic kit for ADHD. Well, thank you for listening. If you'd like free continuing education about adult ADHD, visit us at adhdinadults.com. I'm happy to be program director of that site. Coming in 2022, adhdevidence.org, where I'll continue to curate the evidence for ADHD that we put out in our international consensus statement.
On behalf of Tris Pharma, I would just like to thank Dr. Ferron so very much today and all of you for joining this Tris-sponsored educational webinar. We hope you enjoyed today's presentation. Please use the survey link or QR code on the screen that is provided to provide your feedback and let us know what you would like to see from future programs.